Assalamu alaikum, ladies and gentlemen. And this is the start of the last session, which was not the last, but... So the session is all about hypertension. Quickly starting the session, I would like to invite all the panel of experts on this stage. I would like to invite Professor Mahmoodul Hassan on stage if he is around. Professor Tariq Abbas. Professor Abdul Rashid, Professor Feroz Mehman, Major General Nadeem Fazil, Professor Amir Bandesha, and Professor Khalda Sumro. Ladies and gentlemen, we are moving towards the first talk. That is the hypertension in elderly. This would be delivered by Professor Harun Baba. Please welcome him.
Assalamu alaikum. Assalamu alaikum. It's my pleasure to be here at the end of the session, I think. I have some reservations before I start my talk. Brigadier Nadir is sitting here. Hypertension is the most common disease and the most lethal disease. And the session has been put at the end of the day. You can count how many people are sitting here. So I think you should write down this complaint. I am thankful. I first said this word. But what I am saying is, because if a common disease is not discussed, what is the benefit? What benefit we are giving to the people who came here to listen? Because most of them have left. Anyway, let me start it. हाँ तो सेशन उसी तो जिस तरह था करना चाहिए था. Anyway, मैं इसलिए कह रहा हूँ कि आखिर में आप ऐसा सेशन रखते हैं तो फिर लोगों का जो इंटरेस्ट है वो वेन हो जाता है. तो इसको नेक्स्ट टाइम अगर रखें भी सही तो कहीं बीच में रखें ताकि लोग सुने इसको, उसके ऊपर डिस्कस करें, क्योंकि वन ऑफ द मोस्ट कॉमन प्रॉब्लम. वो कहाँ है यार पीछे? यही है. कहाँ से आगे पीछे होता है? हाइपरटेंशन के बारे में most of you, all of you know what it is. Most prevalent disease in the world. एक आदमी जिसकी उम्र 50 साल है, उसका 90% चांस है कि when he is in his 60s or 70s he will develop hypertension. 65% of the people who are above 60 or around 60 have hypertension. तो ये तो उसकी प्रेवलेंस है. कोई और डिजीज अगर ऐसा है तो मुझे कोई बता दे. And it is one of the most lethal diseases which we come across, leading to complications such as myocardial infarction, stroke, renal failure, peripheral vascular disease. So the more we talk about this, the less it is. And now today's topic, let us come back to this today's topic. It is hypertension in the elderly. ये आपको मैं जल्दी जल्दी दिखाता जाऊंगा. जहाँ कोई स्लाइड जिस पे मैंने ज़्यादा बोलना होगा उसके बारे में मैं I will talk about. तो high prevalence, already I have told you, it's a chronic disease. It is a syndrome actually. Like diabetes is a syndrome, it is also a syndrome. Major cause of morbidity and mortality, and the earlier recognized, the better it is. ये मुख्तलिफ गाइडलाइंस हैं which all of you must have come across, और डिफरेंट गाइडलाइंस अपने अपने फिगर्स दे रहे हैं. हम आखिर में आपको जो आजकल रेलिवेंट है उसका फिगर दे देंगे. ये क्लासिफिकेशन है रफ सी हाइपरटेंशन की, प्राइमरी, सेकेंडरी, हाइपरटेंसिव क्राइसिस, एंड यू कैन सी व्हाट्स द अर्जेंसी एंड इमरजेंसी. अब बात हो रही है हाइपरटेंशन इन द एल्डरली की. The elderly people are a different group altogether from a middle age or a young person. इनमें फिजियोलॉजी डिफरेंट हो जाती है, इनका ब्लड वेसल्स का बिहेवियर डिफरेंट है. The aorta and all other arteries, they become more resistant. Compliance कम हो जाती है, कार्डिक आउटपुट कम हो जाता है, इवन रीनल फ्लो कम हो जाती है. All these matter when you are going to prescribe them drugs. All these matter. और comorbidities होते हैं. मेरा ख्याल है there are only few lucky people who don't have other comorbidities, especially in 70s or 80s. So they are suffering at the same time from other comorbidities, might be having renal problem, might be having lung problem, might be having other problems. And when you start treating these patients, you have to be doubly sure, very careful what this drug is going to do and how it will affect the pathophysiology of this patient. ये सेकेंडरी हाइपरटेंशन के कॉजेज हैं. रेजिस्टेंट हाइपरटेंशन है वो हाइपरटेंशन जिसको एटलीस्ट 3 ड्रग्स इन एडिक्वेट डोजेस पे भी कंट्रोल ना हो रही हो. आप विद एडिशन ऑफ डायूरेटिक ये जाके कंट्रोल हो 3 ड्रग्स पे. मैलिग्नेंट हाइपरटेंशन है, ऑल ऑफ यू आर अवेयर. मेरा नहीं ख्याल कि इस पे जरा ज़्यादा टाइम लगाना चाहिए. You can see here the epidemiology of hypertension. Even neurohormonal autonomic dysregulation हो जाती है. आपके जो baroreceptors हैं ये भी सही तरीके से behave नहीं करते. So this is the effect of old age. किडनी सही तरीके से behave नहीं करती. So what goals we want to achieve? Especially what has been described by different classifications or different guidelines, उसमें क्या goals हैं? एक goal तो ये है कि if somebody, a patient is below 80 years of age, उसका blood pressure आप 140/90 से कम रखें. And if a group of people who are above 80, octogenarians, उनका blood pressure आप 150/90 से कम रखें. तो ये एक broader जो गाइडलाइंस अपना एक ब्रॉड सा एक व्यू देते हैं. दूसरा ये है कि इफ समबडी इज डायबिटिक और हैज रीनल प्रॉब्लम्स देन द बेस्ट ब्लड प्रेशर फॉर देम इज 130/80 और स्लाइटली लेस देन दैट. सबसे पहले हम क्या करते हैं? व्हेन यू स्टार्ट थिंकिंग ऑफ एन एल्डरली पर्सन हु हैज हाइपरटेंशन, फर्स्ट ऑफ ऑल ऑफ कोर्स we go for lifestyle modification. In that there is weight reduction and you can see how much the blood pressure is being affected. DASH diet, dietary sodium restriction, physical activity, blah, blah, blah. So this is what you start with. And still the blood pressure is not controlled, especially when we call it stage 1 or stage 2, you have to add in pharmacological therapy. Should be initiated. तो क्या देना चाहिए? ये भी एक बड़ा important चीज है. In elderly, diuretics, especially thyroid diuretics, calcium channel blockers have shown good results. Superiority, not inferiority, but superiority, or at least same as ACE inhibitors. So usually we start with thiazide diuretics if there is no contraindication. But whenever you give a drug to any patient, and especially elderly, start with small dose. And then you build up the dose. And at the same time, you have to check for orthostatic hypotension. This is very important because the elderly having all other comorbidities and suddenly there is a fall in blood pressure might result in another catastrophe. So the way you start the medication and then you check his blood pressure, especially on sitting and standing, because that is the blood pressure which will lead you how to manage the patient. And if the patient does not is not being controlled by the diuretic, you add a calcium channel blocker or you even can start with a calcium channel blocker. And then you can add a combination of ACE inhibitors or ARBs. So here you can see there was a large trial with the name of SPRINT. And it showed that the blood pressure should be around 120/80. And it showed that that was the blood pressure which was most helpful for patients in this age. And then there was another trial by the name of HIVIT. And that was a trial on octogenarians, people above 80. And it also demonstrated that if you bring the blood pressure around 130/80 or 120/80, that gives the maximum benefits and decreases the morbidity and mortality in this age group as well. So age is not a barrier for treatment, for pharmacotherapy. Any age can be treated with pharmacotherapy if the patient has high blood pressure. ये आपको दिखा रहे हैं established diagnosis of hypertension, essential hypertension, optimal एक चार्ट है. इसी तरह ये different steps हैं. Even in NICE guidelines, this was shown that how you control the blood pressure. If the blood pressure is not being controlled by one drug, you add on the other. और अगर अभी भी control नहीं हो रहा, then you add on the other. And beta blockers have they have gone down to the 4th or 5th place. But there has been in the last 1 decade, there has been a recent breakthrough in beta blocker therapy as well, in which a new beta blocker has come up, which has got vasodilatory properties as well. So this beta blocker, nebivolol, is a drug which can be given to the patients. Hypertension and coronary artery disease. Hypertension क्या है? It causes premature coronary artery disease. So if somebody has hypertension, you have to do your workup to assess his coronary artery disease status as well. BP should be lowered, which I already said. बस थोड़ा सा दे दे. Hypertension and previous stroke. You have to be careful with that. COPD, diabetes. Thank you very much. If there is any question or if you want to make any comments, you are most welcome. Thank you. You want to say?
Thank you very much, sir, for a very nice presentation. सर, ये आपने पोस्टल हाइपोटेंशन की बात की जो कि एल्डरली में बहुत ज़्यादा है. तो आपके एक्सपीरियंस में कौन सी दवा बेहतर है ऐसे पेशेंट्स में जिनको ज़्यादा पोस्टल हाइपोटेंशन हो रही है? क्योंकि प्रैक्टिकली भी ये बड़ी कॉमन प्रॉब्लम है एल्डरली में कि वो इसके साथ आते हैं.
देखिए जी, इसमें 2-3 चीज़ें हैं. एक चीज़ मैं मेंशन करना भी भूल गया था. आई विल कम बैक टू योर क्वेश्चन. आइसोलेटेड सिस्टोलिक हाइपरटेंशन. जो आइसोलेटेड सिस्टोलिक हाइपरटेंशन है वो एल्डरली में ज़्यादा होती है एंड उसमें भी पोस्टल हाइपरटेंशन होती है. तो इसको आपने डॉक्यूमेंट करना है पहले तो ये, एंड देन यू हैव टू डू योर वर्कअप एंड कैल्शियम चैनल ब्लॉकर्स में बी ए बेटर ऑप्शन देन अदर ड्रग्स. बट यू हैव टू बी वेरी केयरफुल इन द डोजिंग, प्रिसाइज डोजिंग एंड टू चेकअप, कीप द चेक ऑन द पेशेंट कि इसका बीपी किस तरह बिहेव कर रहा है. नंबर 1. नंबर 2, एम्बुलेटरी ब्लड प्रेशर मॉनिटर एंड होम ब्लड प्रेशर मॉनिटर. ये मैं अभी बात नहीं कर सका, टाइम नहीं था. दीज टूल्स आर वेरी इंपॉर्टेंट, स्पेशली when you are treating the elderly and when the patient is on drugs. You can monitor the drugs, and the ambulatory blood pressure and home blood pressure readings are a much better readings which will show kisko kya chahiye, rather than the blood pressure being documented in the office of the cardiologist or the doctor.
I think your Dr. Nadar, आपका question था what drugs should be given if patient have the postural hypotension. As you know, mostly commonly the postural hypotension occurs due to imbalance in the autonomic nervous system. So you have to try the drugs, especially you have to add the beta blocker drugs in these patients, non-selective beta blocker, because if you use the beta blocker, the alpha blocker activity increase, they cause the peripheral vasoconstriction and then they decrease the hypotension. But before giving these drugs, you will always think about the precipitating causes. So what things that leads to the postural hypotension? That's the important things. Because there are diuretics, other vasodilators, they are used in diabetic patients and old age patients, systolic hypertension. These patients should be observed, and then if they are not controlled, then use the beta blocker. And other than beta blocker, you have to give the drugs which increase the volume, especially steroids and so
सबसे
on.
इम्पोर्टेंट चीज़ ये है कि आपने उनकी वॉल्यूम डिप्लेशन नहीं होने देनी, क्योंकि एल्डरली में यूजुअली देयर वॉल्यूम ब्लड वॉल्यूम इज आल्सो लो. Number one. Number two, their sympathetic supply is more and their parasympathetic supply has gone down because of the autonomic dysfunction. So you have to check these all things before prescribing.
There is a group of patients who come with the labile hypertension.
Labile hypertension.
Labile hypertension, and once they would come to you, their blood pressure would be normal, but they would be carrying a paper where they had already reported to an emergency department, and the blood pressure would have been documented something like, 180 over 100 or 180 over 120. What should be the strategy in the management of these patients?
Well, patients who fall in labile hypertension, we have got other groups as well, including this, like white coat hypertension, like people who develop hypertension when, who record high blood pressure when they are at home, and when they come to the doctor, the blood pressure is normal. And similarly, labile hypertension is a group which has to be ascertained. You have to put them on ambulatory blood pressure monitor and document when their blood pressure rises. If this is the case, then you have to deal accordingly, looking at what other drugs they are taking, what other, how is their diet, what is their weight, all these things have to be.
I think it's very simple. When it comes to postural hypertension in elderly, don't forget most of them are on alpha blockers for prostate. And that is the real reason for postural hypertension. So all these patients need to have lower doses of your antihypertensive, because alpha blockers itself is a antihypertensive drug. Yeah. When it comes to labile hypertension, I always ask my patients, if the heart rate is up, then only you get very high blood pressures. So it is related to heart rate most of the time. So these patients will do better with low doses of beta blocker, which prevents the rise of heart rate, because blood pressure is cardiac output times heart rate. So whenever they are under stress, during pain, एक तो घर पे एक प्रॉब्लम ही होता है, सर में दर्द होता है, ब्लड प्रेशर चेक करते हैं, तो उस टाइम पे बीपी बढ़ना तो नॉर्मल चीज़ है. So I think you have to explain to them that if it is related to the symptoms, then you deal with the symptoms rather than blood pressure. Now it's very easy in emergency, nurse आके कहती है जी blood pressure बढ़ा हुआ है, तो डॉक्टर कहता है चलो यार blood pressure मुजरिम मिल गया आपको. I think we need to assess all these patients.
इसमें मसूर साहब एक चीज़ है POTS, जिसमें वो ऑर्थोस्टैटिक टैकिकार्डिया भी होता है और ब्लड प्रेशर भी ऊपर चला जाता है, तो उसके लिए भी बीटा ब्लॉकर्स आर इंडिकेटेड.
Low doses of beta
And
blocker.
these days, we are seeing a lot of blood pressure in younger age group. Previously, we used to think about secondary causes and investigate. Now we investigate them thoroughly, and we do not find any underlying cause. And most of them, they are having essential hypertension around the age of 20,
I think it is
definitely higher than
is one of the
before.
disease.
You're right. It's much higher than
I think it is very rare to get hypertension in teens or in 20s without a secondary cause.
So
you have,
I think we are living in a different era. When we were students, you would not think of blood pressure below the age of 50 or 60.
Yes.
But now we are getting it starting at 30. So I think as the society is moving towards faster life, the blood pressure is coming down with age. And moreover, our definition of blood pressure is also getting a little
changing,
tighter.
yes. But what I will again say, you have to go all the way to check for secondary hypertension.
सर यंग एज में तो आप फियोक्रोमोसाइटोमा इज वन ऑफ द डिजीज जिसमें लेबल हाइपरटेंशन और टकीकार्डिया होता है, दैट मस्ट बी एक्सक्लूडेड इन द यंग एज ग्रुप.
देखिए you are right, but I think basic
hypertension is more common
Yes.
in between 20 to 50 years of age. Idiopathic hypertension is common, and then again onward from the 50 to later on secondary hypertension is common. So it can occur in below the age of 20.
Yes, but what I'm saying is, unless and until you do your workup for secondary hypertension, you cannot declare it,
That's true.
Yes.
That's
unless proved otherwise.
Yeah, but in any case, I think you must do your workup before
Yes.
starting treatment in any case.
जी 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 ट्रीटमेंट तो आप करेंगे
In any blood pressure or patient.
इसी
Yeah.
तरह इसी तरह
Next.
Till the next.
Thank you very much. Moving on to the next presenter, and the topic is really important. Accurate measurement of blood pressure. That would be presented by Professor Nawaz Lashari, who is the head of the Department of Cardiology at Dow University of Health Sciences. Please welcome him.
Short and precise.
Bismillah ar-Rahman Rahim. I like to congratulate to the organizers of this conference. Excellent job, well done. So this is actually one of the risk factors, the time management and the late and other things. This is also one of the reasons for the increasing high blood pressure. So we had to, so we had to keep these all things, small things we had to keep all. That's the reason. So everything which is, because these two things that control the blood pressure is the autonomic nervous system, that's not under control. Other is the hormones. And both are not under control. And that's all precipitated by the emotions and other things. So as you know, the high blood pressure, actually, we are, as you know, we are looking the blood pressure, the hypertension, just tip of the iceberg. Why we say that? 42% of the peoples, we are here sitting and our families, we don't know how much is our blood pressure. And out of others, 42%, they know, but they are not taking medicine. So only 10% of the people, all of the population, their blood pressure is control. And for that, so this is a big magnitude. And one of the major risk factor, if you calculate all cardiovascular disease, one of the major risk factors is the hypertension. And this is the actually, I think, the big, all the soil for all the diseases which precipitate the further events in the body, right from the head to toes. So these actually picture remind us my topic actually is the why the accurate measurement of blood pressure is very important. One thing is give the numbers to someone, means give the level, either you are normal, hypertensive stages. That's very important. And second thing, when you accurately measure the blood pressure and you stage these patients, you want to start the lifestyle modification, treatment and the drug treatment, because as you know, once you start the treatment, this treatment will continue for the longer time. As we discussed, 90% of the people, they have no definitive cause. 10% they have the secondary cause. So you have to remain with problems with the, so accurate measurement, not only to make the, label the patient's hypertension, but you have to use for the control of the blood pressure and titration and the risk stratification. So these are the objective why the accurate measurement of the blood pressure is important. And what things should be taken when you measure the accurate blood pressures. This picture reminds us there's a different technology, different equipments were used, and the first equipments that was the blood pressure was measured in the mirror. So this and with advanced different equipments were used, and the dial type meter, then the mercury type, and then now is the automatic devices they came in the market. So this is the evolution in the measurement of the use of the technologies and the measurement of the blood pressure. So we have to know about these things, what are the importance and the advantages and disadvantages of these things. This automatic device, this is our new devices, doesn't need so much training. So anyone can check the blood pressure. Actually, checking of the blood pressure is not only responsibility of the cardiologist, but the responsibility of the every persons which are related to the medicine field, right from the pediatrician, gynecologist, neurologist, and other people, because this problem starts from the birth of the child. So we have to train every person, even the home, the people they are remain in the home, we have to train these people, because later on slides we discuss why we do advise the accurate measurement of blood pressure at the home. This is another device that's used, that's we call ambulatory blood pressure monitor, in order to make the accurate measurement of the blood pressure. 24-hour accurate measurement of the blood pressure is used by this device, that's ambulatory blood pressure monitoring. And the thing, when you measure the blood pressure, after looking these different devices, advantage and disadvantage, the most common tools which is connected with these devices is the cuff. And you have to select the correct cuff sizes, and where to use that is very important. And the arm is the best things where you use the cuff. You can use over the wrist and the toes other, but there is the not reliable for the accurate measurement of the blood pressure. And when you use the cuff, this should be cover the 80% the arm circumference and the 80% the length of arm. And you have to look, the bladder of the cuff is very important. Don't look at the length. The length of the bladder and the width of the bladder is very important when you are selecting the cuff in these patients. So these are the different cuff sizes which can use in the patients, right from the obese patient, normal persons, low weight persons. So these are the different type of cuff size that you can select when you're using the high blood pressure patients. Looking at these devices, there are, if you have the 3-4 devices, suppose you have the automatic devices, you have the manual devices. When you use these devices, manual devices mostly commonly used when your pulse is irregular. If your pulse is not regular, and if his patient is very obese patients, and if the cuff is not fit in this patient, then you use the manual device. Or the patients, old age patients, their arteries are thick, that can be not compressed by the UL automatic devices. And if they have the high blood pressure, then you can use these type of the manual device. Otherwise, automatic devices are very commonly used, but just keep on think, you have to calibrate these automatic devices when you advise any person to the. So what I do in my patients, I say always bring their devices in my clinic, and I check the blood pressure simultaneously and ask the patient to check this blood pressure with their devices. And I make that how much it's accurate or not. Then I say this okay, this you can use that. And I again then tell my student, other persons who are concerned with high blood pressure, then they do the same practice in order to correlate these things. Why the accurate measurement of blood pressure is very important. These are some steps written. The rest is very important. Just keep the patient, just sit on the 5 minutes. And then the cuff size, select the appropriate cuff size, use at the arm, and if they are, and then you follow these steps. Why these all are important? If you look on these slides on this level, in all these things, right from the toilet to 20 millimeter of systolic blood pressure and the 10 millimeter of diastolic blood pressure, variability can occur if you don't follow these rules. So always follow these rules. That's important. Rest, and then you have to ask about before you ask about the tea or the caffeine or the other things, just increase the high blood pressure, exercise, and then so on. And these slides, look on these slides. Just two small cuff, this 10 to 40 millimeter blood pressure, or if a patient not sit back, and if the cross legs 5 to 80 millimeter, and all these things. If patient have the pain, same like the labile hypertension, increased blood pressure, and if you have the pain, so you can expect the 10 to 30 millimeter of the variability of the high blood pressure in these patients. And these slides show why we use the cuff in the arm, why not use in the wrist and the toes. Look on the variability of the pressures in the body, in the right from the head to foot. So mostly I always ask my 5 students, is pressure in the upper limbs high or pressure in lower limbs are high? So majority answers will be the 50-50. So this is another way how to measure the blood pressure. In the home is also blood pressure is important, because This also help out in the diagnosis of two problems. One is the white coat hypertension, other is mask hypertension. Mask hypertension is very hidden problem in our community. And if you know there's we'll discuss in the later slides how much it's caused problem in the community. And in the home, most commonly devices, these are automatic devices, but rest features will be the same. Patient should be sit, rest, don't cross the legs, and the arm should be like this, same things you can use their patients. These are actually the things which, you should inquire about that, and when you use this situation that precipitated these problems. And the prognosis, look on the prognosis of the four type of the hypertensions. Mask hypertension, uncontrolled, white coat, and hypertension. Look on the mortality, highest mortality in the mask hypertension, that's not detected in the population. So you have to educate the population, check the blood pressure at home and take that, sir. And one of the white coat hypertension, labile hypertension. Don't treat treat these patients, white coat hypertension patient, unless you have to look for the evidence of the target organ damage. Once you look saw the evidence of target organ damage, then you start the antihypertensive therapy in patient have the white coat hypertension. Otherwise, there is no need of this. This is another group of the patients, which you shall say the dippers are non-dippers, and these group of the patients detected by the 24-hour blood pressure monitoring devices. And this is also important because the non-dippers have the highest mortality. So accurate measurement of the blood pressure during that is very important for the detection of these problems. And another problem you can detect in this morning surge, you can also look in these patients. Accurate measurement of the morning surge. And another important accurate measurement of blood pressure is to check the blood pressure before taking any medication, next dose. In order to see the effect of the previous drug, that's how its cycle is controlled with that medication, then you have to adjust the drugs according to that way. So this 24-hour blood pressure monitoring is very important in order to check. And this slides actually show that these are the actually steps what you do when checking the blood pressure. So thank you very much for this conversation.
Excellent presentation. I have one query. You said dippers. I think what is the literature says that it should be at least 10% difference.
Yeah.
Dipper
means you are in the sleep, the pressure should be decreased 10%.
Between the day and the night, there should be at least 10%.
10 millimeter of mercury.
If it is less than that, then they are non-dippers.
Non-dippers.
And the prognosis worsens.
Yes.
And the other thing, you talked about different forms of hypertension. One was as labile hypertension, General Saab was saying, mostly related to stress.
Yeah.
And you were saying that no drugs should be given if there is no target organ damage. But they behave with beta blockers. They actually, because the reason behind is stress, undue stress and anxiety. So they are the people who have labile hypertension.
But the white coat hypertensive patients, actually, when they visit or they have some meeting other than blood pressure transiently increase. But if this transiently repeatedly increase and they cause the organ damage, then you have to start the antihypertensive for continuously. For transient duration, suppose generally when you go for the examination, your heart rate increase, then we advise some propranolol tablets just before they are going to exam. These are transient measures you to use. But for the long-term use, you have to evidence for the target organ damage for the labile or white coat hypertension. Yeah, this
excellent talk, Dr. Nawaz Lashari. I just wanted to ask you about these electronic devices which are used to measure blood pressure. Because generally we think they're very unreliable. Sometimes they would be, giving you a reading which would be higher than actual blood pressure, and at other times they would be giving a reading which is lower than the actual blood pressure. So do you know of any device which is more reliable? Secondly, you said told us about the calibration that you do in your office, but then again, same point and same argument that they are not reliable. Sometimes that would be normal, sometimes that would be on the higher side, at other time that would be on the lower side. What are your comments?
I think this is an excellent question. Mostly the patients, they ask these questions. Okay, which devices I have to buy and how do I say this is accurate or not accurate. Actually, the latest guidelines came, there's Gen Z. The devices were used were the automatic devices. And they say that the 10 millimeter of the mercury, their devices show less than we use the manual devices. That's why. No, it's not allowed, but the manual devices used in order to calibrate these automatic devices for that. There is some approved devices, MROS, other devices. They have the approved, FDA approved, or some European approved devices. But for even then, they have some problems. So what we do, what we teach, I teach in my students, my patients, when you feel discrepancy, check the blood pressure with the devices, simultaneously check with the blood pressure with the manual devices, whatever, either the mercury or the NRI type of the device, manually, and then see if the difference is less than 10 is okay. If it's more than 10, because if you say the patients, check the blood pressure at home, then come to me, I will check, then will be the different variability. Simultaneously sit the patient, do the same protocol, ask the patient, check blood pressure with their devices. That should be a standard. Then you check manually and then see how much difference is being in that. So it's the simple way to in order to calibrate. Otherwise, there are some devices, they are calibrated, they are standardized, they are written. Okay, these are and the best device is they're used for the brachial artery.
Recently, they are saying that the patient should sit alone in a room with a device only, and there should be no doctor or technical person. And
Yes.
sit there for
5 minutes
no coffee or no treatment.
for the coffee exercise, 30 minutes.
Yes, and then he should measure his blood pressure himself.
I think the best thing is with these
Professor
devices.
Harun, may I have just a comment? I think we've got so many people from here, from different institutes over here. We talk about dipping, non-dipping. We talked about masked hypertension. We talked about white coat hypertension. All these phenomena, and patients come to us. We talk about labile hypertension. So we've got, I think, people from premier institutes here in Pakistan. We talk about the guidelines and we get the directions from there about treatment of these patients. How many centers over here, they go for ambulatory blood pressure monitoring, office blood pressure monitoring? We've got people from A5C, PIMS here in Islamabad, Dr. Ali Raza was sitting here from Karachi. And because this is such a common issue, when we talk of the mortality, even the white coat hypertension, people say that previously it was thought it doesn't have any long-term complication, but the new data says even those patients with white coat hypertension can have complications in long term. So how often we diagnose the white coat hypertension or the dipping, non-dipping, the ambulatory blood pressure monitoring, the home blood pressure monitoring, because we just go for office blood pressure monitoring. May we have comments from our seniors?
Let me explain.
Please.
I think it's very easy to talk about these things because it's a long-term data and outcome data. And we still do not understand the pathophysiology behind it. Until and unless we understand it, what is really happening, then only you can treat it. Because for labile hypertension, there is no drug yet. Of course, if the heart rate is fast, then yes, beta blocker is there. And when it comes to electronic devices, the advantage really is that it gives you the heart rate. And that tells you that what is happening. Is he symptomatic? Is he under stress? So that's how you can assess whether they need medication or not. I see patients every day, एक single reading पे full dose लिखा होता है दवाओं का. And then they come back with feeling dizzy and all that. So labile hypertension का, yes, data is there, but we still don't know how to manage it.
But so this is not reply to my query. And what I'm asking is, how many people go?
I
for
have
this?
done it for
Yes.
many years, and I do it still wherever, in youngsters particularly.
Dr. Jalal.
Actually, Jalal, there are variabilities are not
We
just
are doing it in Islamabad. We have ambulatory blood pressure monitor in the different institutes, like in the federal government, at the Pakistan Institute of Medical Sciences, and it is being done, and the benefit is being given to the patient.
But
Now, when General Nasir was talking about the standardization of the automatic blood pressure recorders, in the SPRINT trial, what Haroon mentioned, that is exactly how the blood pressure was recorded, by an automatic blood pressure recorder in a quiet room and sitting there for some time, then it was recorded. So I think that the automatic blood pressure recorders like Omron, they are standard equipment. And what you do is that you actually ask the patient to bring it to the clinic, and there you standardize it with your blood pressure apparatus, which unfortunately we are still using the mercury sphygmomanometer, and there you will be able to tell them that this is what the difference is. But you need to take 3 readings, even with the automatic blood pressure recorder, and discard the first one and take an average of the other 2 readings. That will give you the exact. Now, as regards the is the gold standard. Unfortunately,
environmental hazard, that's why we are not using
it. Is the gold standard.
But just, Dr. Shahbaz, just want to, it's because of environmental hazards.
This
environmental hazards,
mercury,
now it's not used.
Mercury, it is because of mercury.
Yeah. But it's not allowed, no more allowed because of that environmental
mercury
hazards.
is actually the poisonous substance inside.
Rather, what you can use is an aneroid.
Yeah.
Aneroid use करें. That's
Aneroid, but I think what.
But just want to add one thing. Actually, blood pressure is something where you have beat to beat variability because of so much influences, extrinsic, intrinsic, and there are various studies which have shown seasonal variabilities in patients. So even that 24-hour blood pressure monitoring is not an answer to, it's really difficult thing to get a base pressure of a patient because of so much variabilities in blood pressure. And even these variabilities, some have variabilities of even 10, 20, some has very little variabilities in their blood pressures. So it's a very difficult subject to get your patient's exact reading. And best is that home-based and out of that influences, and then merging that with 24-hour and other, and then making an impression that that would be the base reading. Otherwise, it's really, you can get a range in your patients.
Well, I think
home-based reading.
I think
that's in the early morning.
Change the source.
But Dr. Fawad, it can be one's personal opinion. But keeping the guidelines in mind, ABPM and home blood pressure monitoring do have their place in the guidelines, despite saying that the blood pressure varies every moment. 24-hour blood pressure monitoring, of course, dipping, non-dipping, you cannot, because that pressure, when you have the cuff you have on your hand, that records BP every 15 minutes. So there's no alternative to that, sir, and it is part of the guideline.
And I think it is, what is important is, just a minute, what is important is to take the blood, if you're taking it at home, it should be done twice a day, and it should be early morning before you do anything, and the last thing at night. These are the 2 times which you have to record the blood pressure. And in 1 week, take it for 3 to 4 days.
So this is actually simple way to record the blood pressures because the ambulatory BP is very costly. So everybody can't afford these devices. So we had to advise the office blood pressure, home blood pressure, and same like the home blood pressure at the morning in order to look for the early morning surge. Because as a general population, we had to select the devices which is applicable to general population. Exactly, the literature say ambulatory blood pressure method is the top so far the assessment of morbidity, mortality is concerned, gold standard. But other methods are also important in order to make the apply in the general population with less cost. So that's another thing to apply the general population. Thank you very much.
Thank you very much, Dr. Nawaz. It was such an extensive discussion. Moving on to the next topic. Again, a hot topic, and in the current era, that is the renal denervation for resistant hypertension. This is going to be presented by Dr. Abdul Rauf, who is an assistant professor at Peshawar Medical College.
Bismillah ar-Rahman ar-Rahim. So, this is from basic to the top. So we will discuss about renal denervation. Before going to that, something about the resistant hypertension. So we must know what is resistant hypertension. So office BP of 130 or more than 80 in a patient who has been prescribed with 3 or more than 3 medications, and one of them is diuretics, or the blood pressure is 130 to 80, then they must have 4 antihypertensive medications. Important thing is you have to exclude the pseudo-resistance. All the things before that was checking the blood pressure, non-adherence, the white coat hypertension, masked hypertension, all these things should be excluded. Then you have to identify and reverse contributing lifestyle factors, discontinue or minimize interfering substances, and screen for secondary cause of hypertension, as we discussed in the previous topic. After that, you add on therapy to resistant hypertensions, either mineralocorticoids or in CKDs, loop diuretics, and even beta blockers. Still, you all have patients who are all on these medication and the blood pressure is still uncontrolled. And then you refer to the specialist, and the specialist think what to do next. Then there was a thought that the renal nerves has something to do with that. And if we can intervene in renal nerves, we can reduce the blood pressures. Because it was, there are different trials on renal nerve denervation starting from 2010. And it was sham control trials and non-sham control trials. You can see most of them are sham control trials. So it's a journey of almost 15 years. And after all these trials, there was guidelines by different societies, but EAC and EAPCI recently have put it class 2A indications to those who have office blood pressure of 140 and 90 millimeter Hg, confirmed by 24 hours, as we discussed, 24 hours ambulatory blood pressure of 130 millimeter Hg, or daytime systolic blood pressure of 135 millimeter Hg, and treated with 3 or more than 3 antihypertensive drugs, and each GFR is more than 40 ml per liter. So this is the class 2A indication by EAC and EAPCI for renal denervations. And class 2B is still there, patient unable to tolerate antihypertensive drugs for long term, and those who prefer to do for RDN with shared decision making without completing the 3 medications. So this is class 2B. Now, different societies have different guidelines, but the SKY and EAC, they have the resistance, intolerant drugs, and non-adherence. If we simplify it, so RDN, resistant, damage, and non-adherent. These are the indication for renal nerve denervation. Now, in these trials, there are 3 different ways being used for renal denervations. One is spiral multi-electrode radiofrequency ablation catheter, the ultrasound-based denervations, and the alcohol-based denervations. And when we compare them, so the long-term, short-term efficacy and safety was shown in radiofrequency ablation. This was queried previously, but in EuroPCR, they presented that they have reduced 18 millimeter Hg systolic blood pressure for 3 years. And they have the safety as well as efficacy issue. So the recommendation is renal nerve denervation through radiofrequency ablation. This was the alcoholic way. This was the balloon So the balloon have some controversies and some side effects, we can say. 7 French catheter used, and depend on the artery size, you have to choose different balloons, and one patient, maybe the branches are 3 millimeter and the main is 8 millimeter. That was the Medtronic base G3 generator, automatic, and this was the spiral catheters, 4 electrodes, and they can fit in 3 to 8 millimeter of any size of the artery, and they can fit in the accessory arteries and all these things. Now, before going per procedure, you have to do the imaging, either CT and MR, and it will give you fibromuscular dysplasia, stenosis, adenoid tumors. These things should be ruled out, and then you have to look for accessory branches, diameters, angulations, and devices, and based on this, either CT or MR, based on renal function and BMI. But the prefers CTA, as previously Dr. Abid said, that it's anatomical, that will give you the proper anatomy, the accessory arteries and size of the arteries. So CTA is preferable in before going para procedure. When you start it, you do the abdominal angiogram and how, where, and why. So we all know it's the pigtail catheter, and with 10 to 20 cc of contrast, in 1 to 2 lumbar vertebra at AP and LAO view. And why? Because to look for renal arteries and accessory arteries. Because whenever you have to renal denervate, you have to denervate all the arteries, either at accessory or the main artery. Then you do selective renal angiogram to look for the size, tortuosity, take-up, bifurcation, course, atherosclerosis, and all these things. And then you decide about ablation planning and procedure-related concerns. Renal artery assessment, this is one of the pictures. You can see that renal artery is supplied mid of the kidney. When you see there's another accessory artery and there's superior accessory artery. So you have to selectively select the renal arteries and look for that. After assessing the renal anatomy, then the procedure is very simple. If the patient is treatable, consider medication for conscious patient. Because this renal nerve denervation have pain, so you have to sedate the patient. It's not the proper sedation, proper anesthesia, but fentanyl and midazolam you can add for that. Then plan your treatment areas. Insert the guide wire, advanced simplicity, spiral catheter, बहुत simple है. जिस तरह हम एंजियोग्राफी में करते हैं कि कैथेटर हम यूज़ करते हैं, IMA कैथेटर है या जटकिन कैथेटर्स है, और 6 फ्रेंच कैथेटर यूज़ होता है इसके लिए. आप वायर क्रॉस करते हैं, वहाँ पे आप स्पाइरल कैथेटर लेके जाते हैं और वहाँ से वायर रिमूव करते हैं, and that set in that place and you ablate that area. You start from the distal and come to the proximal part and switch to the next renal artery and complete the treatment. So the treatment strategy, this catheter, when you remove the wire, it's set like this, and it covers all the renal artery. And usually the emission rate is 2 to 3 times. In main artery, in accessory, it is 1 times. It's about 60 seconds. And their studies show that the 90% reduction in kidney norepinephrine levels. This is the generator. The generator is auto. The energy has been selected, but the 4 electrodes are there. You can select 2 electrodes, 1 electrode, or all of them. There are some difficulties, as in coronaries, maybe tortuous, maybe angulation, and you can use all the way what you are using in coronaries, the buddy wires, the slippery wires, and the guideliners and microcatheter to introduce the spiral catheters. Now, there's always talking about the safety of the renal nerve denervation. So, in all trials, there's very few vascular 0.3%, in one mortality 0.3%, but it was due to some other reason, not due to renal nerve denervations. So in last renal denervation is a relatively straightforward procedure. To date, very encouraging safety profile. RDN is 8 transitional point of wider adoption. Based on high hypertension prevalence, RDN numbers will be overwhelming for catheterization laboratories. RDN should be prepared as a day case procedure, and therefore it is important to adequately plan the procedure and prevent complications. We need to welcome it in our country. In hypertension registry is on the card by PHL, and Dr. Ali Raza is there. We are looking forward. We have a meeting in Europe PCR with the Medtronic. It will soon bring it into our country. Thank you.
Doctor?
Yes, you can come over here.
It's very simple procedure and it brings down the blood
We can
pressure.
hear you when you're talking, when you hate surgeons.
So this is something else. So this is also surgeon is not involved in. So, so renal arteries denervation, the process is very simple actually. It's a very simple procedure which can be done. And the guidelines are accepting it a lot. The rest of the world is accepting it as well. I think because we spoke about it, but the first thing is the registry to be completed for the hypertension because we need to know the prevalence and the incidence and everything about the hypertension. So that's the first step. And the second thing is this, that because it can bring down up to 10 to 15 immediately of your blood pressure, systolic blood pressure, just after the procedure. And it does bring it on even later on. So it's not just on table, you can see 10 to 15 millimeter drop on it. And then later on, you can see further drops in it. You have to continue your antihypertensives with it and then reduce them later on as well. Younger patients have been offered this procedure now in Europe and everywhere as well. So I think from the Hypertension Society, this is something to consider as well.
What I remember is the first renal
For
denervation that
how
was...
long is it effective? Because are you going to stop the antihypertensive treatment in these patients?
So we don't stop antihypertensive immediately at that time. We continue it, but if the patient's, depending on his blood pressure, we keep on monitoring, like you do the regular checks, and if it's not requiring that many medications, you cut it down and slowly come to the desired level then.
So what is your experience of denervation in Pakistan?
So denervation, because the catheter Medtronic is just going to bring it now very soon, the DRAP is going to register it, so it is on its way, so it's coming. But me and Rauf, what we were talking is that we need the registry to convince the companies, convince the people about it, that there is so much hypertension and so much resistant hypertension and so much young people having hypertension. So I think we have to take it step by step, but the catheter is going to be available. Probably we will be doing our first case in the next few months.
Thank you.
I think, Dr. Rauf, just let me ask you a question about renal denervation. I think the indication arises only once we label patient as resistant to medical therapy. Patients are using this treatment. I still remember the first renal denervation way back, Dr. Fawaz sitting here had done it in ICVD. There was a patient who had been treating for the last 10 years, a young patient, Hafiz-e-Quran. His blood pressure used to remain systolic more than 240, 250 and diastolic more than 130. So I remember we kept that patient on 5 antihypertensive drugs, sort of refractory hypertension. He was getting treatment. When he used to travel from Quetta to Karachi, I used to tell that just tell the physician that when you are here in Quetta, I beta block you, I give you even calcium channel blockers for rate slowing. His heart rate was that fast. And the metabolic work was done, the endocrine work was done multiple times, and the imaging was done. Still, the diagnosis is not made, and the patient still coming. Renal denervation in 2017 was done. So what that's just a single case, and I mean, that cannot be... Yeah,
I think what is important.
I think
so. What we observed in that patient, just
what is important is that you have to exclude pseudo-resistance. First, unless and until you have done that, you should not endeavor to do RDN. It should be pseudo-resistance first that should be actually excluded.
You see, sympathectomy is a very, very old concept. I think more than 50 years ago, sympathectomy was done and blood pressure would come down. But over the period of time, they regrow.
Yes.
So I think we'll have to see, you have 3 years data. Does it maintain the pressures there or it begins to creep up again? We don't know. So long-term outcome, we still have to wait and see about these things. And I think that's the main reason why initially it did not catch up.
Yes, sir.
So,
Sir,
the catheter has.
Not all patients respond. Not all patients respond.
Sir, according to the data, all patients respond
All patients
immediately,
respond, sir.
as well as 18 millimeter Hg per.
ना वो तो यार sham procedure ऑर्बिटा ने भी बता दिया ना.
Let me explain. The guideline says class 2A recommendation for resistant hypertension, and then the resistant hypertension is well defined what is resistant hypertension. So we exclude all the causes. Class 2A recommendation, because you have cases, let me tell you, you have a patient, young lady, they want to conceive, and the blood pressure is not controlled with ARBs, without ARBs and all these things. So there are cases if you have something, some mobility in your hand, it is something like that you have 3-4 colorful suits and you want to wear, if you have suit you can change it. So RDN is one of the fine suit, is coming for antihypertensive. They will reduce the medications for specialized population, and the guidelines are coming in because the data is going for 5 years, then for 6 years, in a new trial is also in the pipeline.
And sir, it is not the.
Innovation, no doubt, and it should come in. What I'm saying is, do all patients respond?
Sir, initially all the patients. Sir, a long-term data because it's still coming up, but one other question which I wanted to respond is that the catheter has improved. So now you have to do actually the whole length of it except the parenchyma. So that's the main thing. I think previously my experience from UK was this, that we were not that meticulous in doing all of it, but now it has to be very meticulous about doing it. Long-term data will come out, sir, but there is, yes, they do regrow. They can come back again, but you can do it again as well. So
Spiral 2 trial actually shows some benefit.
Yes, sir.
Spiral doesn't show it because due to type of the catheters.
Catheter they have.
Initially the 1 or 2 pole catheter were used. Now
they've
the
got
spiral
4
type of
poles
4
and much
poles
more
and it's a
depth.
spiral type of catheter, and there's a spiral 2 trial that show the benefit of this catheter, and that's why they are putting in the 2A recommendation.
All right, moving on to a very difficult topic. That is the difficult issues in the management of blood pressure, to be presented by a senior, very senior faculty who needs no intro, Professor Shahbaz Qureshi. Please welcome him.
ये काम कर रहा है?
जी सर.
Thank you very much. I think a large number of the questions have been answered. It should be 10 minutes, not 8 minutes. Okay. So I'm going to talk about the tips and tricks for the most frequent problems, and resistant hypertension is one of them in hypertension management. How do we define hypertension? That is very important, whether it is in the younger patients or in the elderly. And here we have the cutoff value of 140/90. And we know that as the blood pressure increases from 115 and 75 diastolic, there is an increase in cardiovascular risk in these patients. This is important. So the definition is pragmatic and used to simplify the diagnosis and decisions on management. The office blood pressure of 140/90 defines the level of blood pressure at which the benefits of intervention exceed those of inaction. Inaction, physician inertia, that is important. Also, when we look at the different levels of hypertension, we have to see, as Mansoor said, a proper evaluation, hypertension-mediated organ damage. That will determine the stage of hypertension and how you are going to manage your patients. Stage 1, uncomplicated. Stage 2, when you have a presence of hypertension-mediated organ damage, diabetes or CKD, and the presence of cardiovascular disease or CKD in stage 4 or 5. This is how you should classify all your patients, look at the different levels of blood pressure, and evaluate the risk factors in your patients so that you can manage them properly. Dr. Lashari talked about a proper evaluation of blood pressure. This is how you should actually follow this principle as to how you should take the blood pressure. It is extremely important. Perhaps Lashari forgot to say that you have to mention the blood, you have to measure the blood pressure in both the arms. And always treat the blood pressure which is higher level.
कुछ चीज़ें hidden होती हैं सर, वो समझने के लिए होती हैं.
I just wanted to remind. So now we talked about masked hypertension. You see, my patient has evidence of hypertension-mediated organ damage. However, the clinical blood pressure always seems normal. Now, does this patient have masked hypertension? It affects 15% of the people who have a normal blood pressure at the clinic. The prevalence is greater in younger people. That is what you have when you talk about labile hypertension. And in men, smokers, and those with higher levels of physical activity, alcohol consumption, anxiety, and job stress. Diagnosis criteria include clinic blood pressure less than 140/90, but 24-hour blood pressure is more than 130/80, and home blood pressure 135/85. So you need to take both the ambulatory blood pressure and home blood pressure recording. A tip to consider that masked hypertension is more likely if clinic blood pressure is in the high normal range. The clinic systolic blood pressure 130 to 139, consider out of office blood pressure screening. So this is the tip which you should follow whenever you want to find out about masked hypertension. Another important point is that there is an association between the blood pressure, which is masked hypertension, and a sustained hypertension. The all-cause death is the same. So masked hypertension is not a benign condition. You need to actually diagnose it and treat it. Should I treat it? The trial evidence is lacking, but high risk is evident in these patients. Then treat, especially if they have hypertension-mediated organ damage. Use home blood pressure or ambulatory blood pressure monitor to monitor their blood pressure control or treatment, and target home blood pressure should be less than 130/80. This is in case of masked hypertension. You should treat it. Now, this is very important. You see, I don't think my patient is taking their antihypertensive treatment. How can I check? Poor adherence to the antihypertensive treatment is well recognized. And that is why I say that a large majority of resistant hypertension basically is pseudo-resistance. More common with multiple pills. You give them a number of pills, they will not take them. Adherence tails off over time. Initially, they will take the medicine, but as the time passes, they'll start reducing the medicine. Poor treatment association is associated with a poor prognosis, and identifying poor treatment adherence can lead to better blood pressure control. So this is extremely important to find out whether your patient is actually taking the drug or not. And how would you do that? Check the urine. And you will find out if there is the metabolites of the drug, which you can detect in the urine, and then you can say whether, in a large number of patients, what has been seen is that the urine is devoid of any metabolites of the drugs. That means the patient is not taking the drug. And non-adherence to the antihypertensive medicines, according to the, if you have the number of medicines or the pills you increase, non-adherence increases in these individuals. Then you also want to directly observe the therapy, witness medication consumption followed by ambulatory blood pressure monitoring and home blood pressure, .ABPM or home blood pressure monitoring. Drug testing of urine or blood, extremely important. And then once you have the results, you discuss it with the patient that this is what I think, that probably you're not taking the drug. Re-emphasize the importance of the treatment benefits. You need to motivate your patient, and they will take the drug then. And then use a single pill combination. A combination therapy would be much better than giving them a number of pills which the patient will not take. Also, the other the thing which doctors are worried about is that when they put them on RAS inhibitors, they find that their serum creatinine goes up. And if it goes up, they stop the drug. This is wrong, because this is actually happening because of the RAS blockade. The efferent vessel becomes dilated. And as a result, the intraglomerular pressure drops. And that is why the serum creatinine level goes up. So in these cases, you should persist with the drug, and the benefit you will give to your patients, even in those with chronic kidney disease. And this was shown in this advanced study as well. So reducing blood pressure with any drug will reduce the eGFR by 10%. Decrease is expected within 1 month of starting the RAS therapy. So remember that it will come down. And then if you persist with it, it will improve. So RAS inhibition reduces this risk and should not be discontinued unless reduction in GFR is more than 30%. This is important. And potassium also increases with RAS blockade, especially in advanced CKD. There you can give them the potassium binders. Check kidney function within 1 month of initiating treatment with the RAS blockade. When do I refer a patient who's hypertensive to a specialist? When I suspect a secondary hypertension in these patients. Younger patients less than 40 years with grade 2 or more severe hypertension. So only in those patients, younger patients who have resistant hypertension, think of secondary hypertension and rule out the causes of secondary hypertension in these patients. Or a sudden the aggravation of blood pressure in these patients can also point out that there is secondary hypertension in these patients. And when a more detailed assessment of hypertension-mediated organ damage will influence a treatment decision, and when the referring doctor thinks more specialist evaluation is needed in these patients. When we talk of resistant hypertension, just a few minutes for that. Always think when you are giving your patients at least 3 drugs, and one of them is a diuretic. And if they do not respond, and if they're taking the drug, in the dosage, the maximum dosage, because if you give a haphazard treatment and reduce the dosage in these patients, you will find that they will have resistant hypertension. So this is important in your patients. Confirm treatment resistance, exclude pseudo-resistance, and identify and reverse contributing lifestyle factors. This is very important. Drugs are important, but lifestyle management is also very important, and this should be the first management in your patients, non-pharmacological management in your patients with hypertension, and discontinue or minimize interfering substances. Like Mansoor talked about the alpha blockers. You reduce the dose there, then you will find that the resistance will reduce, and screen for secondary causes of hypertension and the pharmacological treatment. What is the reason why the patients poorly adhere? It's a 50 to 60% of the time the patients are poorly adherent. It's a side effect of the medication. If a young man gets a postural hypertension or other side effects of these drugs, he's not going to take the drug. Then complicated dosing schedules. If they have to take it in the morning, in the afternoon, in the evening, once again, they're not going to take it. Poor relationship between the doctor and the patient. If you don't talk to the patient, in fact, don't talk to him, talk with the patient. And inadequate patient education, memory of psychiatric problems or poor cognition, cost of medication, all these are the factors for pseudo-resistance. Then which are the drugs which if they are taking, because in the elderly, they take a number of drugs, and they can interfere with the efficacy of your drugs, like the non-steroidal anti-inflammatory agents. So you have to ask your patient for these drugs. Then the causes, obstructive sleep apnea, primary aldosteronism, extremely important, renal artery stenosis, renal parenchymal disease, drug-induced or heavy alcohol use or thyroid disorders. Rule this out. Then you will be able to treat your patients, and I think a large number of them have pseudo-resistance. Then use potent thiazide diuretics, use drugs which are like indapamide. They are better drugs to treat your patients with hypertension. Switch to loop diuretics if there's a problem with the kidney. Increase the dosage if necessary and monitor the plasma electrolytes and the enzymes. So you can use spironolactone in these patients or bisoprolol and doxycycline in these patients with hypertension which is not responding, or you can add amiloride in these patients. So this is the schema that you have to follow. Ultimately, in resistant hypertension, add MRAs and add drugs like alpha blockers. They will reduce the blood pressure in your patients. So take general measures, talk to your patient, and advise about the general measures. Always remember, talk with the patient and not to the patient, and you will be able to reduce the blood pressure of your patients. And then we heard about renal denervation in our patients, but actually, first we have to identify it is not pseudo-resistance and go to the maximum dosage as possible. If still the blood pressure does not respond, then I think renal denervation has a place in this. Thank you very much for your attention.
Thank you very much, sir. Moving on to the next topic. Emerging therapeutic approaches for persistent hypertension. It is going to be presented by Professor Jalaluddin Achakzai, who is a professor of cardiology at Bolan Medical College. And I assure you all, my patient audience, this is the last presentation of the day.
Assalamu alaikum. Well, first of all, thank you very much, the organizers, for having me here. I believe hypertension healers should not be hypertension shooters. So we talked a lot about hypertension. I think this is cardiology update, and here I thought something probably we are not in our practice, something to talk about hypertension other than medications that we use in our daily practice. So in the next 10 minutes, I'm going to talk about resistant hypertension. A lot has been talked about already. Renal denervation, Professor Raouf has covered that area. Baroreceptor activation. We know that autonomic nervous system has key role in blood pressure control. Device-based therapies, renal artery stenting. Now, what are the new drugs in line? Lifestyle intervention that is very much ignored in blood pressure management, and alternative medications that we have can be adjunctive therapy. So combination therapy, when we talk of resistant hypertension, already been said that when blood pressure, when we use 3 drugs for a patient at optimal doses, including diuretics and blood pressure not controlled, we label patient as resistant hypertension. And for that, Professor Shehbaz said one thing very important, that you have to rule out pseudo-resistance. You have to confirm that the patient is taking medications. And how to confirm? Thank you very much, sir. You already explained that. Apparent treatment-resistant hypertension is the term used in epidemiological studies that is referred to cases in which patients meet the criteria for resistant hypertension but have unverified adherence or medication doing or dosing, or have not undergone out-of-office blood pressure monitoring to rule out the white coat hypertension. So risk of resistant hypertension, just like hypertension, when hypertension is resistant and blood pressure stays high, we say it is silent killer. It affects heart, it affects brain, it affects kidneys, it affects peripheral vasculature. It is important to identify what are the common causes of resistant hypertension, and as was mentioned, what are the factors that lead to resistant hypertension on the part of the patient, on the part of the clinician. So on the part of the patient might not be taking those medications, patient might not be compliant, and on the part of the physicians, the precision of the medicine might not be there from the physicians. So these are the factors that need to be ruled out before labeling patient as resistant. And apart from resistant, when we use the four drugs, and that's also resistant hypertension if patient's blood pressure is controlled on 4 medications. So what the guidelines say, we have to optimize these 3 drugs, and we have to rule out pseudo-resistance before labeling these patients as resistant. Those patients who are not controlled on 5 medications, we label them as refractory hypertension. So how to go about it? I think Professor Shabazz has already explained. The next drug in pipeline is mineralocorticoid receptor antagonist that has to be added, and then vasodilators, hydralazine. These are the drugs that we can add on in the pipeline, and the centrally acting drugs that can be added on. So move from here. Those patients who are not controlled on these drugs, being labeled as resistance, what are the adjunctive therapy that we have for those patients to offer? Renal denervation, already been talked about it, so I'm not going to touch on it. And we know that is class 2A recommendation in those patients where blood pressure stays more than 140/90 after ruling out pseudo-resistance and after labeling patient as resistant. So I'm going to talk about baroreceptor activation. We know what are baroreceptors. Baroreceptors are the sensors that we have in our carotids, carotid arteries and aortic arch, which senses blood pressure, and that takes the message from high pressure, goes to the central nervous system, and from there on blood pressure controls via controlling heart rate, via vasodilatation, and blood pressure gets controlled. So that's the thing which controls high blood pressure. And similarly, when the blood pressure goes down, these baroreceptors, they sense blood pressure as hypertension, and from there the message goes through to the central nervous system via afferent fibers, and from there on, what is the compensatory mechanism is tachycardia, vasoconstriction, increasing peripheral resistance, and through that way the blood pressure rises. So that is the natural response of high and low blood pressure, baroreceptors control. And age is one of the phenomena, as Professor Mansoor said, that a time comes when the baroreceptors stop working, and that's why blood pressures, the arterial thickening, that increases and blood pressure stays elevated. So there are devices used. These devices are used for controlling blood pressure, and they reduce blood pressure from 18 to 28 mm of mercury. The long-term data still is awaited, but the short-term data about it is good. So they've got cardioprotective effect, and we know once blood pressure is controlled, the LA size starts reducing, the LV thickness stop increasing, the safety and efficacy of patients with systolic heart failure, they've already proven in patients, and the intensity of BAT in cardiac insufficiency was titrated to avoid bradycardia and hypertension. We know these barostim devices being used in heart failure patients. The vasoprotective and metabolic effects of bad therapies, high central BP and increased pulse wave velocity are independent risk factors of cardiovascular morbidity and mortality. So what do they do? The European hypertension guidelines, they define as pulse wave of more than 9.6 meters per second as an independent cardiovascular risk factors. So they reduce pulse wave velocity, and through that mechanism, they are helpful for friendly heart. So in the interest of time, I'm just going to move. What are the other device-based therapies? We've got arteriovenous anastomosis at the femoral level, the arteries and the vein, between them, the anastomosis is created. What does they do? They offload from arterial line, from arteries to veins, and that's why they decrease blood pressure, but they're not without complications. The long-term data still awaited. These are the device-based therapies that can be helped. What was the trial done on them? The ROX control hypertension trial, the first randomized control trial which investigated the efficacy of AV fistula in human hypertension, that showed after 1 year systolic office blood pressure and ambulatory blood pressure decrease of 27 and 14 millimeter respectively for systolic and diastolic. for office blood pressure and ambulatory blood pressure. Despite its efficacy in lowering blood pressure and the manageable venous stenosis events that account for 30% of patients, the multi-center sham control trial Control Hypertension 2 was terminated at an early stage due to heart failure concerns, putting the final nail in the coffin of this novel therapy. So that the data wasn't acceptable, and that's why not became part of the treatment. Pacemaker, we know pacemaker in many of the hypertensive patients are already there. These pacemakers, इनसे ये काम लिया जा सकता है कि cardio neuromodulation therapy. It is the recent introduction in hypertension disease. In this respect, the moderator system, which was developed in a dual chamber design aiming to reduce the left ventricular ejection volume by altering the atrioventricular intervals. The AV intervals को reduce करके sequential short and long intervals. The clinical evidence suggests that the cardiac neuromodulation therapy, CNT, could be effective and safe device for hypertension patients who are resistant to other treatments. So these pacemakers can be made use of in the future for controlling blood pressure because these devices are long-term, lifelong kept there. So renal artery stenting. Who are the patients where renal artery stenting is indicated? We know about 5% of blood pressure is because of renal vascular diseases. And the prevalence of atherosclerotic RAS is particularly high in patients with documented atherosclerotic diseases, especially 18% of coronary artery diseases and 25% of peripheral arterial diseases, and in end-stage renal failure and heart failure. Notably, however, not every RAS is responsible for an elevation in blood pressure. That's why every RAS is not indicated for stenting. Since renal hypoperfusion is necessary for the chain of events described above, blood pressure elevation depends on the degree of the lumen reduction. So the more the stenosis, the higher the chances of, the higher the indication, the more the indication, the stronger the indication for renal stenting. And for them, it is said that the stenosis more than 70%, just like in coronary, or if there is the gradient more than 10 across the lesion, makes an indication for renal stenting. So resistant hypertension and atherosclerotic renal artery disease confirm first treatment resistance, check for barriers to successful treatment, and work for secondary causes, and only then makes an indication for renal artery stenting. Who are the candidates for renal artery stenting? Those patients with flash pulmonary edema, those patients having bilateral renal artery stenosis, those patients with failed kidneys, those patients with single renal artery stenosis but having failed kidneys, those patients with sudden rise, dramatic rise of blood pressure despite being on treatment, or those patients who are on AC inhibitors shooting their blood pressure and going uncontrolled. They are the candidates to be stented if they have got renal artery stenosis. So where does renal artery stenting stay in the guideline? They stay just like renal artery denervations, class 2A indications in patients where it is indicated. Patients with a rapid deterioration of renal function defined as more than 30% decrease in eGFR over less than 3 months. And RAS also benefit from a revascularization, as has been shown by several trials. So what are the novel, in the interest of time, just skipping through these slides, because every I think novel therapy in itself is a talk. Anti-aldosterone agents, yes. May I have, sir, a couple of minutes more, just like. So we've got this pathway. The work has been done on RAS pathway, natriuretic peptide pathway, endothelial system pathway. That's the pathway which is used for. Now, this is very important. Precision medicine approach, traditional approach, evidence-based approach, stratified medicine, personalized medicine, individualized medicine. This is very important. I think many a times we go on a fixed formula of treating our patients, giving them ACE inhibitors, ARBs, beta blockers, calcium channel blockers. We have to individualize our patients. Who are the responders and who are not the responders? We treat two patients, one patient with 180, 90 blood pressure on ACE inhibitor, and we treat a second patient. Maybe they are having the same blood pressure. One patient responds, the others do not respond. So we have to take those factors which are hindrance in the pathway. That's called precision medicine used in chronic. chronic disease conditions. For precision medicine to work, two essential objectives that need to be achieved. First, the disease needs to be classified into various subtypes. Second, there must be targeted therapies available for each specific type. On this basis, patients can be subgrouped into different subtypes and they're treated with appropriate tailored therapies. So this is just a precision medicine integrated modules.
Pressure is increasing.
Hypertension is going on.
Babar Saab.
Hypertension increasing.
I take your point. I take your point that it's such a common condition.
Blood pressure
It's
बढ़
got
रहा है.
so much complications. So I'm going to tell few new things just in the last few slides. Babar Saab has been my partner for long, my senior. So he can stratifying patients based on renin profiling. So let's skip this trial. Sympathetic nervous system, I think, does play an important role. Autonomic nervous system, we see sympathetic hormones of fight, flight, and fright. We have to defend them. Whatever medications come, they work on this system other than the RAS system. And we have to activate our parasympathetic system more to keep blood pressures low. And what are the things that work on parasympathetic? So by the way, what does sympathetic system does? It does affect the severity of hypertension. It does affect different phenotypes of hypertension. In 24-hour hypertension, जब हम बात करते हैं dipping, non-dipping, reverse dipping, it's all sympathetic nervous system that affects. When we talk of target organ damage, again, sympathetic nervous system does work. But in the interest of time, just again going through and skipping it, salt-sensitive hypertension, we know about it. So lifestyle intervention, I would talk about this. This is very much ignored. How often we deal with our patient and how often we advise them to follow these things. Believe me, I've got personal patients having 190 blood pressure, weight 100 kg. They've reduced their weight to 75 kg and their blood pressure has gone down from 180, 190 to 130. And many of our patients have just gone off treatment without medication, their blood pressure control. So this is an area I think most of the physicians that we have to, we have to encourage at society, at community level, that weight reduction, healthy lifestyle, reduced intake of dietary sodium, enhanced intake of dietary potassium, physical activity, these are the factors that they need to be worked on. Recommended healthy behavior in adults with hypertension, again, an area of focus. Now, this slide, complementary and alternative medications. What are the CAM therapy? So, इसमें अगर हम देख लें तो हम बात करते हैं डार्क चॉकलेट की बात करते हैं. Chocolate reduces, dark chocolate reduces blood pressure, but how much chocolate needs to be taken? And what does chocolate do? Chocolate में flavonoids होता है, flavonoids. Flavonoids, they've got antioxidant property, they've got vasodilator property, they've got endothelial improvement properties. So because of these properties, they reduce blood pressure. But how much chocolate needs to be taken? The dark chocolate, it needs to be how much? बहुत ज़्यादा लेंगे, weight बढ़ाएगा, calories ज़्यादा होंगी. So how much? Anyone from here? So this was the interesting part of my talk. So 30 milligram, not more than that. If you take more, what will happen? It will increase. The calorie intake will be more.
Dr. Jalal,
it cause obesity.
Meeting होनी है हमारी अपनी.
जी sir. So pretty much relevant. Coenzyme Q10. Coenzyme Q10, very important again in blood pressure. Those patients who are already having these drugs in them, they've got some effect, but the message is not to write them. These are just adjunctive therapy. Melatonin, again, a hormone that keeps our cycle, our night cycle, and they've got endothelial properties that increases, that reduces blood pressure transiently, but they don't have long-term data. Vitamin D, but I'll support this Qigong. Qigong is the Chinese ways of reducing blood pressure. It's sort of a, no, it's a sort of a physiotherapy, proper course of it, and once you do it, it releases stress, it improves the release of endorphins, pleasing hormone, it releases stress, and it does improve blood pressure. Chinese data pretty much on that. So slow breathing and meditation, acupuncture के बारे में कहा जाता है, again Chinese way of treating a lot of diseases, but what does acupuncture do? It reduces stress, it again improves endothelial function, and they've got some data, but it is for transient blood pressure transient blood pressure drop. It's not, the long-term data is not there. On even acupuncture, the RCTs are there. So concluding my slide, the best evidence, well, unlucky to be the last speaker.
Best evidence therapy is the
Let me go to
behavioral therapy.
the 2023 ESH guidelines give RAID a class of recommendation 2 with a level of evidence B. Several guidelines support renal artery stenting by, again, level of evidence 2 in those patients where there is the right indication, where the medical treatment is failed. I just doubt, जैसे Ali Raza साहब ने बताया, because we are interventionists, we always stent. We are more looking for stenting lesions, for doing interventions. So I doubt once this renal denervation comes, maybe I believe that people would be having 160, 180 blood pressure, and we'll be just indicating them, yaar, aapki renal denervation kar lete, blood pressure control karega. There is a lot of chances of overdoing these renal denervation as well. So guidelines need to be, the concept needs to be clear about it. Baroreflex activation therapy in resistant hypertension is a programmable device with a significant and sustained blood pressure reduction with the regression of left ventricular hypertrophy. For resistant hypertension, personalized therapy is conditioned by the recognition of a group of traits that may differentiate the response of individual patients. A low plasma renin can be considered a very specific marker for sodium excess. Thus, renin profiling can address the therapeutic choice towards diuretics. So diuretics again are based on those those things. So here comes my last things are about precision medication. Precision medication is something that we lack in our practice. I believe in my practice at least. So we have to improve our precision medications. We don't need to follow just कि हमने लकीर के फकीर बने हैं वही line को follow करनी है उसी को. We have to individualize our patient and we have to treat individually those patients. Thank you very much for your listening.
Nervous system, as you said. So it's a very interesting thought I get. What about comparing it with centrally acting medication like methyl-dopa? So is it the same brain centers that is that it works through, but we don't know much about methyl-dopa because that works centrally. So could there be a comparison between the two?
So to my knowledge,
I don't know yet.
There's no data on it. What the 3 trials have been done.
No, I'm not saying there is a data. I'm just saying it's a thought that has come to my mind because that's a central acting drug.
So the thought, let me come to your thoughts because the centrally acting drugs are proven, time tested.
No, but
they
what part of brain do they affect? Does it compare with the baroreceptor activation? Because that also works through central nervous system.
They cross the blood-brain barrier. They cross the blood-brain barrier.
No,
they don't work on the baroreceptors.
No. But methyl-dopa, and that works through central nervous system, isn't it?
Yeah.
And baroreceptor activation is also stimulating the brain center.
But the signal, where does the signal go from? The sensors are just like the pacemakers. These devices are surgically put here in the carotids. Because may I just sort of clarify it? The baroreceptors are here in the carotid arch.
But it works through vagal stimulation. That means through brain.
The sensors are here. The sensors are here.
Yep.
So these devices are surgically implanted here.
I know. Yeah. But they stimulate the vagus nerve basically, which is again the brain.
Because
that's why I'm wondering if there could be. Ali Raza?
Yes, sir. Baroreceptor
actually make some comment
sense
on this.
The high pressure.
Centrally acting drug, and this also vagal stimulation is also through central nervous system. So I don't know. This is just a thought.
Actually, that's a very political reply. Thank you.
Baroreceptors actually they are a protective mechanism. They actually regulate normal blood pressure, but due to prolonged constant level of high blood pressure, they become ineffective. So this activation, artificial activation, activate the vagus nerve, as you say, same thing. Yes, sir.
they activate the parasympathetic system and they decrease the blood pressure. But the
चलो भाई, thank you.